A patient is rushed through the ER doors. They can't speak, and one side of their body is completely paralyzed. The clock is already ticking. Deep inside of the patient's head, millions of microscopic brain cells are rapidly suffocating. The medical team faces an immediate fork in the road. They have to figure out exactly what is causing this crisis. It could be an ischemic stroke, where a blood clot is blocking an artery, or it could be a hemorrhage, where a weakened blood vessel has ruptured inside the skull. Guessing is not an option. The standard treatment for a clot is a powerful blood thinner. Give that to a patient who is actively bleeding from a rupture, and you will kill them. To get a definitive answer, doctors turn to the computerized axial tomography, or CT, scanner. This machine takes X-rays from multiple angles to map the interior of the skull without ever making an incision, delivering a complete three-dimensional picture in seconds. But the machine only outputs a dataset of gray pixels. Surviving a brain emergency depends entirely on a physician's ability to decode that murky anatomy and translate it into a precise medical intervention. To read these images, we have to understand that a CT scan doesn't capture a traditional photograph. Instead, it measures exactly how much X-ray radiation is absorbed by the different tissues inside the body. This animated scale shows how doctors track that absorption using Hounsfield units, or HU. It's the standard digital measurement for tissue density. At the far black end is air, measuring -1,000. Dark gray represents water and spinal fluid, right at 0. Biological brain tissue sits in the mid-gray range between +30 and 45. And dense bone registers as bright white, climbing up to +1,000. Looking closer at this scale, we can see the extremely narrow numerical gap between the brain's gray matter and white matter. Gray matter consists of denser cell bodies, hovering around 40 HU, while white matter contains fatty myelin, dropping its density slightly lower, closer to 30 HU. A radiologist's core skill is simply recognizing when these natural baseline density values shift. If a patch of brain suddenly registers too high or too low, they know disease or trauma is present. There is a biological hurdle here. The CT scanner captures over 2,000 distinct shades of gray, but the human eye can only differentiate a few dozen of them. This visualization illustrates a software technique called windowing. By compressing the scanner's massive dataset into a narrow, targeted range of Hounsfield units, doctors force a murky gray background to snap into high-contrast black and white detail. ER teams actively adjust this software to hunt for different problems. They select a brain window to view soft tissue, switch to a bone window to expose microfractures in the skull, and use a blood window to isolate active bleeding. A CT scan is a flexible dataset. Radiologists have to actively interrogate that data, manipulating the contrast to uncover the pathology hiding inside. When hunting for a hemorrhage, doctors look for extreme density. Freshly clotted blood is packed with dense proteins, making it show up as a stark, bright white, or hyperdense, mass against the gray background of the brain. This diagram illustrates how the specific geometry of that white mass reveals where the bleeding is located. An epidural hematoma, bleeding outside the dura membrane, forces its way inward, creating a convex, lemon-like shape. A subdural hematoma spreads out between the membranes, creating a long, concave crescent. An ischemic stroke creates the exact opposite visual signature. When brain tissue is starved of oxygen by a clot, its cells swell with water. Because water has a lower Hounsfield value than brain tissue, the dying area appears as a dark, hypodense patch. On rare occasions, the scanner captures the hyperdense vessel sign, a bright white clot physically wedged inside one of the major cerebral arteries. On the monitor, bright white signals an active bleed, while dark gray points to dying tissue. Recognizing this difference instantly dictates the ER doctor's battle plan. Beyond blood and clots, doctors are looking for signs of mechanical stress. The adult human skull is a rigid, unforgiving bone vault. When a bleed or severe swelling expands inside it, the healthy brain tissue has nowhere to go. To gauge this pressure, physicians look at the midline of the brain. If this natural dividing line is physically bowed to one side, they call it a midline shift, a clear indicator of dangerous asymmetric pressure building inside the cranium. If that pressure goes unchecked, it causes a catastrophic event known as herniation or coning. The expanding mass physically crushes the brain downward, forcing vital tissue out through the foramen magnum, the opening at the base of the skull. A visible midline shift or herniation indicates that the vascular crisis has transitioned into a total mechanical failure of the brain. We are back in the ER, staring at the monitors. The gray pixels have rendered their verdict, and the medical team knows exactly what physical action they need to take next. A bright white mass confirming a hemorrhage means an immediate trip to the operating room. Surgeons must drill into the skull to relieve the intracranial pressure, drain the blood, and attempt to repair the ruptured vessel. Conversely, if the scan reveals a dark, hypodense patch and definitively rules out a bleed, the team is safely cleared to administer systemic clot-busting drugs to restore blood flow. Before the 1970s, neurology relied heavily on clinical deduction, forcing doctors to guess at pathologies hidden beneath the bone. Then, engineer Godfrey Hounsfield developed the first commercial CT scanner, allowing medicine to see inside the skull with exact precision. The CT scan serves as a real-time, three-dimensional survival map, decoding the complex geography of the human brain to save millions of lives every year.